let me just give a little sort of overview of research in the U.S. as I understand it, as it's going on, and then maybe we can focus on some of the specific questions. There are three areas of research that regularly appear in neurologic literature, orthopedic literature. One area is basic research, work on motor units, work on anterior horn cells in the context of polio, in the context of other diseases that affect those areas. What weakens them, what can you do to strengthen them, stuff that could overflow and actually benefit in post-polio research as well. Corollary with that is, developing animal models of post-polio. The typical animals that we use, mice, for instance, don't get polio. And, certainly it's hard to get a model of post-polio in an animal that you don't want to wait around for 50 years until it develops post-polio or whatever the timing is. And I believe, a couple of researchers back east have actually developed an effective mouse model for post-polio. They succeeded in giving polio to the mouse and in actually a year later showing the same type of dropout of motor units, axone withdrawal that is seen in humans with post-polio. It'll be an excellent way to study post-polio mechanisms and also a way to have an animal model for drug trials. With the basic research going into the immune mechanisms as it affects the health of recovered nerve cells in post-polio, obviously using these animal models to test out the actual pathophysiology. And that brings us to the next area of research, which is human research into the natural history of post-polio and then setting up clinical trials in post-polio. Mayo Clinic has been doing an enormous amount of natural history research for a number of years. They have some very good publications, which I think have been good guidelines for us. The failed symptomatic trials for pyridostigmine and modafinil, I think, reflect back on the need to design clinical studies using very, very rigidly described groups of polio survivors so that you're not mixing apples and oranges and trying to observe an effect. I think the work is going on now with IVIG, taking off from the role of the immune system as at least one factor that may be triggering post-polio symptomatology, modifying it with IVIG. This work began in Sweden. I first heard about it in 2000 at Warm Springs, and since then, they've extended their work. The Norwegians are working on it, and Dr. Delakis at the National Institutes of Health has also been working on it as well. And I think that's probably the biggest clinical research breakthrough that's aimed at treatment. Third area is going outside the actual motor unit definition of post-polio, looking at other symptoms that seem to accompany post-polio, including accelerated effects of aging in other areas, developing diabetes, arthritic changes that may be more commonly seen. Rancho Los Amigos, had a large grant and has had a long ongoing study of aging with a disability, which included its polio survivors. I think providing a lot of useful information about the increased health risks that many polio survivors may have, and whether it's related to some underlying general aging mechanism, whether it's just the problems of immobility that seem to accentuate it. I think their research will probably show that. We've done some work here in sleep. And underlying sleep disorders. I know individual groups have looked at speech and swallowing, and there are publications about that. I've got folders of articles on small studies, single patient case descriptions, looking at each of these areas. The effects of vision, I haven't seen any publications on. I think some of the other areas that people have questions about probably deserve to be looked at. But even funding a small clinical trial is you need money. And in the 90s, there was just a drought regarding research funding in the United States for post-polio. It picked up a little bit, but it's still not enough that every worthy project can be funded. But you can start small. You can start with a small study of a dozen people or 20 people who seem to share concerns about vision and explore it with the money that you do have. But I think we will need more money for clinical research, even if the basic researchers seem to have their own sources, because basic research does apply to more than one disease. I think think it is known that the polio virus didn't just hit spinal motor neurons, that it also hit central motor neurons. And that there is documentation of change, and there are changes seen on MRI that would correlate with that. So I think it is, a given now for most people dealing with it. Because of that, you would expect to see changes in post-polio syndrome affecting central pathways. I have seen individuals who have developed upper motor neuron findings, which is not something you would expect to see, but with changes in central pathways, which are upper motor neurons, you can see the emergence of brisk reflexes, even outgoing toes, and things that appear to be spasticity related as opposed to motor unit or weakness related. You can find changes in brainstem motor neurons, especially in people that had bulbar polio, where there was documented clinical evidence in the acute syndrome. Affecting weakness in pharyngeal muscles, weakness in accessory muscles of respiration, and other cranial nerve areas. So I think central motor effects have been well seen. Some interest in effects in not voluntary muscle groups on a central basis, but involuntary muscle, autonomic nerve centers in brainstem and brain areas, effects it might have on blood pressure, effects it might have on cardiac function, effects it might have on sleep. And I think there is published evidence to say that these areas have been able to be monitored and seen to be involved as well. Are there cognitive changes in post-polio? People describe brain fatigue. And I think that is a real phenomenon. What the actual hardwiring of it is, I don't know. Because most of the pathways that I just indicated aren't typically involved with concentration and alertness, with the exception of the reticular activating system in the brainstem, which could be behind the descriptions of brain fatigue and central fatigue. So I think there is growing basic science evidence that that the brain is involved as well as the spinal cord, and that the symptoms in post-polio may include symptoms in those areas as well. And that was why I wrote my little grant application to look at signs of inflammation that might be affecting brain structures. Didn't get funded, but I think there is going to be more and more attention paid to that. Certainly, work being done back east, and I forget who the researcher was, with magnetic resonance spectroscopy. I think it was Dr. Trojan was working with that, looking for changes in brain chemicals that would correlate with changes in nerve activity when you can't actually pick up atrophy or nerve cell loss on simple imaging is going to be very important, to follow treatment protocols. A lot of work being done in spinal cord injury, which is an area of tremendous demand. In replacing spinal long tracts. I think a lot of that research is going to be very applicable, whether it's growth factors or stem cells, to polio survivors. So I know that spinal cord injury groups are working very closely with some polio groups, at developing these technologies, but again, it's still very much at the animal research level. It's not being done in people yet.
Years?
5 to 10 years. I would say. There was one pilot study done using a nerve growth factor, insulin-like growth factor. It was being studied in Lou Gehrig's disease, ALS, and the clinician who was running that study, had a group of polio patients that he wanted to see if it would be of help to them at all. Studied it, found, some improved recovery from fatiguing exercise, but no obvious change on muscle biopsies or nerve biopsies. So it was suggestive, but then he didn't have additional funding to really carry on a larger study. So I think there are unplumbed areas that are crying out to have research done in them, where we are at a point where we could be doing clinical trials, and it's just lack of funding, lack of interest on the part of drug companies. It's an orphan disease in a way because it's a disease that's felt to be dying out.
The goal of it is to, like I said, twofold. One, to encourage people to think that yes, it's important to study polio. Number two, to help young researchers get data so that they can use that to apply for a larger grant or for seed money. And the one 2 years ago, or it wouldn't have been 2 years ago, 2 grants ago, was the young lady that did the research on polio people or women in menopause and did that large survey of that. There really has been very little done with women and disabilities in reference to menopause and some of the women's issues. And so she did a good job with the survey and was published in several journals, and as a result of that then she applied to the National Institutes of Health for a grant and received a 3-year, I think, I'm not sure, was it $250,000 or a $500,000 grant to continue to do more do more work with people with disabilities and issues in reference to menopause, etc. So that was a perfect example of what we wanted to have happen. A lot of the research that she did and the funding went for spinal cord injury, but that's okay. I mean, there's stuff you can learn from that, and also there's some money there for spinal cord injury. There's not a whole lot of money right now, to study, polio specifically.
Exactly. And what's the research that's just been funded this year?
The one this year was looking for a biomarker.
Yes.
I mean, everybody who works within the post-polio community or the post-polio world, if you say, well, what is post-polio syndrome, and then is there a test for it? The answer is no, there's no test for it. It's a diagnosis of exclusion. And so there's been some work over the last several years about that perhaps that there is, and it's always been a speculation, there's some sort of an immune response or something going on, with polio people who have, more than, muscle more than joint, deformities. I know what word, I hate that word deformities, but I'm never quite sure whatever word to use. But the mechanics of walking and those sorts of things, there are some, polio people who have some really, really very dramatic neuromuscular or just real dramatic new weakness. So there's always that, question as to what's going on, and so checking in, into the immune response of polio people. So this is a young lady that received the grant, and she's at the University of Arkansas Medical Sciences. I don't have that quite right. I never quite get that right. But in Little Rock. And she's a young lady who's in immunology, and she's originally from Bangladesh and has family in Bangladesh. So polio is a little bit more fresh in her mind, from
Still
being
happening.
at home and
Yeah.
happening. There's, I think in 2000 and 2001 there were still cases in polio. But she applied for a grant to look for a biomarker to see if there was anything in the blood of polio people that would, could be to say that this is what people who have post-polio syndrome, shows up. So the research that she did was inconclusive, but I think it's worth, doing, further research into it.
There's, I think most of the significant amount of research was done by Dr. Perry with the GATE lab and the pathophysiology lab. We've done a small sort of pilot study on using creatinine. That's the protein powder type of a thing that they use for muscle building. We actually we kind of ended it as a pilot. What we found is that those that were loaded with the creatinine, they actually did better. Their strength improved. But when we measured them 2 weeks later, they were worse than those that didn't have that. And the reasoning was that they felt better, so they went and did more stuff.
They didn't pace.
They didn't pace, and we found that to be true because we did the activity and the fatigue log, and then there's just, though we've told them, that you, regardless of whether you feel better or not, you can't overdo it. But we saw sort of this thing like before, after, and then should. Whereas the other people who didn't get it, it's like before, after, it's pretty much the same, and out, and it's all kind of the same. I'm kind of interested in looking at these kind of, especially these kind of people that I would consider like high risk for what appears to them like a sudden decrease in function, but actually it really is not so sudden because they were probably functioning at a 3+ level. And then when they go down to this 2+ or 2 level, then of course it's anti-gravity muscle, and that's like sort of the tipping point.
Yep.
And so, I mean, I'd like to kind of study that population so that so the patients could sort of know that, okay, I'm in this high risk zone here. I need to be very careful.
Let me just tell you.
Yeah.
Almost every study that's been done on the polio population is skewed, is biased, because there's no way that you can get a true random sample of the polio population. I mean, the folks at risk is what you're interested in, you know. That's the denominator. And it's either defined by those who have polio virus attack them, or it's defined by those who actually had paralytic polio. You know, to be practical, you could really only include those that had paralytic polio. Although we've discovered that there are a number of people who didn't know they had polio, but they come down with symptoms so similar to post-polio syndrome that after they visit 6 neurologists, they read an article that describes their symptoms and they say, boy, I didn't have polio, but I'm sure experiencing what they're describing. They come to the clinic and we stick a needle in all 4 limbs and there's major polio in all 4 limbs. It's incredible. So anyway, but for practical purposes, if you're looking for the population at risk, you'd have to start with just those that had obvious, some kind of paralysis, atrophy, whatever. So that would be potentially one population at risk. Another population at risk would be those who are having new symptoms. So those might be people who have what's called the late effects of polio. But, you know, these are folks spread out all over the community, all across the nation. How do you get a random, you know, there's no directory, there's no, you know, inventory of all those people. I mean, and it's the same problem with any medical condition. It's just that when you have more common things, you can just get large numbers. I mean, so when you're talking about heart disease and diet, I mean, you know, you can, like the Framingham study, you know, was able to get thousands and then follow them for a long time. And a lot of the information we have about how to manage diabetes, for example, comes from, you know, multi-center studies where, you know, you have 10,000 patients maybe. You know, how many reports have you seen in the literature about polio that deal with, you know, 6 patients here, 9 there, 13, 24? I mean, and they're all patients that are included in the study by what's called convenience. It's a convenience sample. These are people who have chosen to come to your hospital, to your clinic, and have walked through the door. You know, and even then, you may not take everybody in succession. You might take the 1st, the 3rd, the 9th. You know, people who can come back, people who are interested, people who don't have complicating illness. I mean, you know, it just becomes very difficult. So knowing all of that, it just makes you really very, very particular about how you interpret and read those studies. And that applies to the brain studies, which are all intriguing, but, you know, it's just really hard to say for sure what it means, because even getting a good control population is hard. You know, if you get a population that didn't have polio, I mean, then you can look for maybe people that had polio but not, but find that is impossible. So you might find people that have polio but aren't having new symptoms.
Research in sleep apnea, osteoporosis in polio patients, but there was one that is much more recent on the immune system.
Yes, this was part of a study on fatigue in multiple sclerosis patients and post-polio syndrome patients. It was funded by the Multiple Sclerosis Society of Canada. And basically we were measuring certain inflammatory markers or cytokines. These are substances that are released by macrophages. That's part of the inflammatory response. And anyhow, so we had normal controls in that in the study as well. So our main purpose to assess these markers was to look at associations of these inflammatory markers with fatigue and multiple sclerosis. And polio patients were being used as controls for the multiple sclerosis patients, but surprisingly, we did not expect to find this. When we just looked at the values of the markers or compared the two different patient populations with controls, we found that in post-polio syndrome patients, there was an increase in most of the markers that we were assessing, and a few of the cytokines compared to normal controls. And so that was the main finding, that there is evidence of inflammation in post-polio syndrome patients. And these markers were found in the peripheral blood. Previously, other investigators from Sweden had found that these similar or the same cytokines are increased in the cerebrospinal fluid, and they did assess these markers in the peripheral blood, but a different way than we did. We actually assessed the actual levels of the markers, whereas they assessed actually, I'm not really sure how they did it because I'm not a basic scientist, but they did it in a different way than we did. So they found in the cerebral spinal fluid, but not in the peripheral blood. But they had a very small population of patients. It was less than 20, if I remember correctly. And we had around 50 patients in our study, so it's a much larger group of subjects. So that was the main finding. And then we also found that one of the markers, TNF-alpha, was associated with pain, muscle pain in these patients. We looked at genital pain, muscle pain, and joint pain, and there seemed to be a specific association with muscle pain. That doesn't mean that these inflammatory markers are the cause of pain, but it suggests that this may be may be important or contributing factor. The reason why we don't know for sure that this is the cause of pain is, number one, this is the first study to do this. It's a preliminary study. And also, this is a cross-sectional study, meaning it's sort of a snapshot view. And to really see if something is the cause of something, you need to do a prospective study. But plus, also, the other problem with these markers is that they're very variable. You know, they vary a lot during the day, and also if you have, you know, a virus, a cold, they go up. So, you know, there's a lot of things that can make these markers go up. So I'm not sure that this is the final answer for a diagnosis. I don't think it is. But I'm not an expert in this area. I'm not an immunologist at all. I'm a rehabilitation medicine specialist. I just happened to find this in a study that I was doing. But I was doing this with an expert neuroimmunologist. His lab measured them.
Research is something that kind of is my drive now, as opposed to the development of the program, which has happened over the years. I think has been phenomenal, and we've gotten a international reputation, but we still haven't put out research other than some posters probably that we've put out. So my goal for this year was to have our team, the polio team, try to determine what kind of research opportunities we have because of the volume that we see. And by seeing enough patients, I think we have some ideas of what we expect to see in our patients. And if we put out research or put out some information with regards to that, that will help other countries or other clinics to develop that. One of our research opportunities, I think, are going to be with sleep apnea in the polio population. We're seeing approximately 100% across the board of polio survivors who have also suffered from sleep apnea. So that's something that we have noticed. So now we have to go back and do just a research of our patients to see is that holding true and what's been done about it. The other interest is with osteoporosis and the disuse in the affected limb, and also teaching the people doing the bone density scans that they need to do the affected side and not just do what the protocol is. Even at a large facility like we have at Mass General Hospital in Boston, which is a world-renowned facility, I had a fight with them to tell them that no, you have to do the side that I asked, not the side that's the protocol. And I spoke to the director there, Dr. Slovic, who understood that, and after we repeated some studies and they saw that the unaffected side was normal and the affected side was abnormal, they realized that maybe they should listen to what we said. So that's another retrospective study and prospective study that we can do with regards to osteoporosis and its effects on the polio survivors, and preventing that and being ahead of the curve on that. So those are kind of the two main things. There's plenty of other things as well. There's always going to be research opportunities.